Good afternoon, everyone. My name is Prajwal. I'm a data scientist at Northern Data Alliance, and I'm going to talk about the use of NLP in clinical coding process, specifically to assist the clinical coders. A little bit of a background about clinical coding. So it is the process of analyzing the clinical statements and documents for the patients and assigning clinical classification standard codes, which are ICD-10 and OPCS-4, to the patient episode. ICD-10 codes, like everyone knows, are used for classifying diseases and other health conditions, while OPCS-4 codes are used for classifying interventions and surgical procedures. The purpose of clinical coding is basically it helps us get a snapshot of the population health, also along with the insights or trends over time. At the same time, one of the important uses for clinical coding is that it helps with the reimbursement processes for the hospitals for the care that they have provided to the patients. If you look closely at the journey of a clinical coder while coding for a particular patient episode, then to start by accessing the medical records, which can be on different systems. They include operation notes, clinic notes, lifestyle documents, and etc. The next step would be to analyze this unstructured and structured data, and then referring to the standard codes, which is ICD-10 and OPCS-4 codes, to assign the relevant bits as per the analysis that they have done in the previous step. They conclude the process by entering these codes into the system, which is often a manual process again. With this project, we're aiming to assist in the first three steps of this process using natural language processing, as most of the data that they use is in free text format. Now, based on the previous steps, some of the key challenges that are faced during this process are with time and complexity. So if you think about accessing different medical documents, which are placed in different systems altogether, that increases the time they require for having this information at hand. We aim to implement the system in such a way that the information that they require is in one single place for an easier access to the information. The next bit is going manually through the huge free text data at a time that they're spending to pick out the relevant bits from the whole data, because there's a significant time component involved in this particular bit of the process. The next step or the next challenge would be the vast clinical coding classification standard materials or ebooks that they have to refer to. This requires a complex training as well as understanding of the roots and associations for particular cases, and that requires an experienced coder to complete the process. And when an inexperienced coder is in such a place or such a process, it can be difficult to grasp the specific roots or complexities for some of the use cases. To average these challenges, it boils down to around 20 minutes spent per patient episode to be coded, which is high enough time even for an experienced coder. But in case of an inexperienced coder, this time can even increase above 20 minutes for each patient episode. To discuss the current work, it is important to mention that we are at an experimentation stage in a multi-year project journey there. From the start, we've employed a multidisciplinary approach so that team data science, the clinical coding, and the coded data and standard assurance teams are coming together to discuss the challenges, the approaches, and most importantly, the validation for whatever work we're trying to achieve here, just to make sure that we're achieving the standards that are maintained by manual coding as well. These are some of the documents that are usually used for the clinical coding process. All of them have pre-text information. The discharge summary and the operation notes are the most commonly used pre-text documents over here. Now, if we consider one of the operation notes and the content of the operation note as an example, the idea is to apply a natural language processing technique called named entity recognition and linking. As the name suggests, we are trying to recognize entities from this pre-text information, and the linking refers to linking to the medical ontologies, which is ICD-10 for the diseases and conditions, and OPCS-4 codes for the procedures. Now, when we apply this, the pre-text should look something like this. Now, if we look at the model output, we can see multiple entities or concepts have been identified by the model. But let's focus on the first two that we can see over here. The terms right and decompressive craniectomy have been identified, and since the model is able to match them with the previously trained data, The model is also able to give out suggestions with OPCS focus for these two procedures. At the same time, we can also look at the different terms that the model has failed to identify in this example. The terms like evacuation of acute SDH or ICP catheter should have been identified with the model as well as any other clinical coder would do. Since this is an actual output from the model that we're developing right now, this is a good demonstration of the progress that we've had so far, but at the same time, also the areas of improvement going further. Now, coming back to the rightly identified entities, so the terms right and decompressed splenectomy. If we compare these OPCS codes for both of these entities to the actual contents of the coding classification standards, which are available for OPCS codes, and compare the results of the suggestions that the model has given out, we can see that it is going to be very helpful for someone who is inexperienced to narrow down the search to identify the correct OPCS codes for these particular entities in this case. Bringing back the information that we are trying to feed in through this tool that we're trying to develop, along with the previous documents that the clinical coders have access to, this supports the key idea to the project, which is to assist and not replace. So essentially, what we're trying to do is that with the current clinical coding process, we're trying to introduce suggestions which are provided with evidence and ranked diagnoses and procedures for the clinical coders as an assisting tool, as a suggestions tool, to simplify some of the easy tasks. Now, this is going to be very helpful with some of the procedures or cases which have lower complexity but higher volumes. And any time that is given back to the clinical coders through this process implementation, they can spend the same time on more complex cases which have even more complex roots and associations in it that we need to consider and which are quite difficult to map in tools as of now. In all of this process, the key idea that we are focusing on is that the clinical coders should be in charge of the whole process throughout the whole task, so that we can maintain the assurance of the rightfully coded data at the end of the whole process. To discuss some of the technical elements, we're using SPACY, SciSPACY, and MedCat, quite similar to the previous presentation. These are the Python NLP packages specializing for biomedical text data and big data, and MedCat, which specializes in electronic health records for entity recognition and linking. So like the previously demonstrated examples, the MedCat helps us bring together the functionality of entity recognition as well as the linking to the same box. And the basis for the linking part, which MedCat uses, is on SNOMED CT codes at the minute. But we have used NHS resources to further extend these mappings to ICD-10 and OPCS codes. So much similar to the example we saw earlier, the model is able to give out suggestions that end up in ICD-10 and OPCS codes based on the matches it finds for the particular entities that it has recognized. To some of the progress so far, we are in the experimentation phase, like I mentioned before, with the entity recognition and linking. And further testing and improvement to the process are required, with fine-tuning the model or even adding terms to the vocabulary of the model, so it is able to identify more terms and it is not missing out any information in the process. Because the main focus here is that we want to focus on avoiding false negatives to improve the performance in such a way that no information is lost while giving the suggestions to the clinical coders. At the same time, for the future, we have planned to implement a ranking system for these entities. So if you have observed before, the models like MedCat are able to identify entities, but it is identifying multiple entities. And considering the total scale of pretext data we have available, we would end up with just a lot of suggestions for the clinical coders, which might not be as helpful as we intended to be. So the ranking system is aimed to use the patient history data as well as the data for other patients who have similar conditions to rank these entities in such a way that we can provide them a certain ranking value, essentially pushing down the non-relevant bits at the bottom of the suggestions, and the important suggestions would get at the top of the list for the clinical coders to refer to. And at the end, we want to encapsulate all of these functionality into a web app, which essentially would be a challenging task to make sure that we are considering aspects of integration into the current framework or the current systems that are used at the trust to make sure that the data access is smooth and secure as well at the same time. And also considering the user access for the clinical coders to integrate the system into the current workflow that they have. And like any other project, that would be involving continuous testing and monitoring for the system at the end to maintain the performance and to keep up with the technological advancements as well. So that's my time for today, and I'm open to any questions if you might have.
Do you have any question?
Snowmet, do you think the same thing is totally with Snowmet?
Yeah, so Medcat originally uses SNOMED codes. So the implementation that we are trying to achieve can be achieved easier with the suggestions being in the SNOMED CT format. But since the codes that are used at the trust are ICD-10 and OPCS4 codes, we've extended the mapping a bit further to not just refer back to SNOMED codes, but having suggestions in the format that is suitable.
Okay, thank you. Do you plan to incorporate code things that are critical code without any suggestions?
Yeah, so there's a tool called Medcat Trainer, which is a part of the Medcat project. If we implement that, that would be like a validation step. So initially, when we have a running system, we can implement that to as a validation step going further, so that whatever performance the model is having, we can make tweaks and changes based on the suggestions that the clinical coders might have. Yeah.
And one more. No.
Thank you. You talked about being a multi-year project. Yeah. Clearly, you're not going to tell us how many years it is, but you've got a good feel. Are we talking 1, 10, 20, before we get to a point where it's almost AI generated real-time codes?
Well, to be honest, considering the complexity of the free text data, as well as the complexity with the rules that are involved in clinical coding, we don't have an estimate of the number of years that we would be spending on this. But the idea is that we want to do this in smaller bits. That's why it is assisting tool, so that it is going to make some mistakes on the way, but we want to make at least a working prototype in the next few years, just to make sure we can baseline the performance and then get suggestions from the clinical coders, because it is going to be a long journey, trying to make this as a process which can be acceptable as a standard, which is comparable directly to the manual coding. Yeah.